Good evening, Sudeep.
Good evening, Anup.
Welcome to the Digital Excellence Pharma Academy, a partnership between Medicine Man and CredoWeb, so that we use this opportunity to equip the Indian pharma professionals to familiarize themselves with everything related to digital, and they can begin their digital adoption journey slowly but steadily with the inputs from veterans like you who have done a lot in this space. So before we go into this topic, Sudeep, I just want a quick 5 minute intro about you for our audience who may not be familiar with you. So, how did you land up in pharma? What's your journey like, and where are you now?
Yeah, thank you, Anup. Thank you, Medicine Man and CredoWeb. Appreciate engaging me in this discussion. And Anup, we have been friends for long, along with Deep and Salil. So in a way, all of us have a similar journey, And I do believe Indian pharma to be one of the most meritocratic industry.
Yeah,
You and I would not be here if there
right.
was no uh, uh, responses and appreciation for performance. So I
Right.
think the reason why I'm here, why you are here, is because of that meritocratic nature of the Indian pharma industry, and that's the reason I appreciate it so much. So, like most of us, we started at the bottom
Right.
and raised uh, through the ranks, thanks to a lot of mentors along the way, guide, friends, teachers, and I'm thankful to all of them for what they have done to my life. My of course the family around it. It's not easy to work in pharma in India for a long period of time, and that's what has been the journey. Uh, Basic education, like all of us have started in 90s, was a BSc in anthropology
Wow.
and biology, and I think it really shaped my thought process in connecting the dots. And the anthropology really shaped the way I look at connecting the dots in healthcare, and of course people management. It really helped me, and I really appreciate why I studied anthropology. The reason, of course, was very different. Why I studied anthropology, and then for the last 2.5 years, I'm currently based out of Brussels. I work for UCB Biopharma, and I take care of a portfolio which I would say is a choice that I made about 8 months back. It's a combination of a lot of jobs. My official title is head strategic engagement and network, and I also co-lead social businesses in Africa and India. So that's what I do at this point of time, and I'm happy to be amongst friends and especially with you, Anup.
Yeah, I still remember. I think the last time we met was somewhere in the Phoenix Mill Mall over a lunch with Deep Bhandari.
Yeah, indeed. Indeed, and I think your daughter got married or something like
Oh
that.
yes, yeah, yeah,
Yeah, and we had a fish meal, and as usual, the Bhandari was vegetarian meal.
So it's great to connect again from Phoenix Mill Mall to you've gone all the way to Brussels, but thanks to the digital media and this platform from CredoWeb, we are able to connect. So I think you have a great view from where you're sitting, Sudeep. You know what's happening in India because you'll always remain, your heart will remain here, and you're in Europe. What are some of the recent developments that you are seeing, not just in healthcare, but because of this pandemic and so many other factors? And what kind of impact do you think it will have on healthcare and maybe even on pharma?
Yeah, just before I go there, I would say that I do have a very strong connect with India, simply because I'm trying to start a social business pilot in Mumbai. So there are a lot of stuffs that I'm trying to do in Mumbai, part of the social business initiative that UCB Biopharma has taken. So coming back to the larger trends that we see, and I'm sure terabytes of evidences are generated every week and produced to us. But I thought of seven, which I think is more or more summation of what I believe is impacting us. And these trends are reduction in travel.
Reduction in
Now, travel. The first one that I think is reduction in travel, and it's going to stay, whether it's a interlocation or intralocation. The second trend that I see has impact on how we are currently behaving and shall behave is dilution of big infrastructure. So big urban centers, super hub models will be diluted at certain point of time or getting diluted at this certain point of time. As we can see that head offices, headquarters are empty. And
Yes.
even if you go there, you can't go there more than 10%, 20% of the population. The third one, which I think is the current trend, is reduced uh, and deficits in budgets. And I'm talking about at every sphere. And we, as the economy is impacted, we see a significant amount of reduction in budgets in all parameters. Though there are moratoriums, et cetera, are been announced. But finally, there is lesser money to spend. Um, from an Indian perspective, I would say that the import versus export and foreign exchange will play a critical role. How do we look at our budgets? One of the good effects would be availability of experts. And what do I mean by experts? Because this whole COVID situation will drive job losses, which means experts will be available at a reasonable cost,
Right.
and also a lot of people would like to stay back in specific geographies
Right.
versus relocating to better pastures. The fifth point I think is most for most, and which is something that India is doing very proactively. Ayushman Bharat is a good example of most for most, and I think we can look at a Nordic model. And fortunately, I have worked in Nordic for 18 months when I first came to from Europe to Europe, and the Korean model of healthcare is something that will happen most for most. Geopolitics will be a big trend. Partnerships, how corporation partners with governments, rise of nationalism, and we see it so much in across the world. Um Information versus knowledge, a big debate, and related to it is fake news. Okay, so this I think is the sixth point, and my seventh point would be technology and data. So these are my 7 points that I think are bigger trends, which has impact on currently what we're doing and what shall we do in future.
So great. I mean, you summed it up well. Reminds me of Mega Trends by John Naisbitt, if I'm right, uh,
Yeah,
and Future Shock by Alvin Toffler. I think one of the best things as reps in our days was we had to wait a lot of time in the railway station. Uh,
yeah,
and this was before mobile phones and television sets came in, right? So the only thing was that I still remember those book cards of the Wheeler Book Co.
yes,
And my first book that I picked was, I'm okay, you're okay, and I was really fascinated by that thought process in that I never come something across. So, and then the reading journey has continued, and so I'm not really in any way, if one has been reading, there has been a lot of people like John Naisbitt and Alvin Toffler talking about the disruptions that's going to come in. And more significantly, I remember reading Charles Handy, and he wrote a fantastic book called The Empty Raincoat.
right,
It's based on some sculpture that he saw. And he saw that corporations are relatively a new concept and an idea. It's just 100 years old. But if you look at villages, the communities.
Yeah.
They are very old and they're ancient. So he says, if you want to look at longevity, you will need to look at the village structure, the community structure, and how it is designed, and what you can adapt from that to the corporate, so that you can increase its longevity. So it's very interesting that you said that headquarters is losing its importance.
Yeah.
So for all of us who were medical reps, to come to headquarters was the ultimate dream, because that's where the C-suite and the big shot chat, and things happen. So that's great. The 7 trends that you have said. So there will be impact of these trends on healthcare as well. So what are some of the trend impact that you see because of these trends on healthcare? How is healthcare shifting or altering because of this?
So as I said, you know what, all these I have put up my healthcare lens and said all these 7 points from a healthcare lens perspective. So if we have a reduction in travel, okay, we are fearful of travel, then how is it that I'm going to reach out to my physician? Okay, how is it that I'm going to get treated? So there has to be an alternative method, and I'm sure there's a lot of discussion happening on telemedicine, and I'm sure that you and Salil are trying to find out solutions in terms of how it can be, and that's terabytes of data are produced on what can be the alternative method. The question again is, which is fundamental and a little bit of an anthropological, is that our willingness to change, okay, and the decision making. So would we take the right decision, move forward, integrate it to the current situation, or would we defy it, say that maybe it's not going to impact me, and face the consequences? Okay, so each of those 7 points have a very long term, impact on overall society, and not just as human, but as overall world. And I do believe, when we look at the climatic conditions, all those discussions on climates, this 7 has a very, very important impact on even on climates. Okay, so that's something that I think are integrated together. And I remember this economist and historian called Sanjeev Sanyal. Okay, now he says a very important thing, and I like to quote that we learn in silos. The way you and I have learned, all our education have been in silos. However, we don't live in silos.
That's
We are
right.
in the interdependent um, people. Okay, so if we think our learnings are in silos, but we behave in independently, probably it's not going to work, and it has never worked in ever in human history.
So that's a very important thing that you said, and specifically I would bring the silos, the context to pharma, and the marketing operates in its silo, the SFE operates in its silo, the sales operates in its silo, and Salil always likes to say that they need to function as one, so that the rep knows what are the interactions that are happening from the marketing with the customer, from the medical with the customer, and even the supply chain. How are they working things out so that drugs reach ultimately the consumer. So great thing. So let's get to the topic for the day. There's always been a big buzz about patient centricity. So I want to come to the fundamental question when we talk about patient centricity. Are we really going beyond that buzzword? Because Delhi police have this great buzzword which says "with you and for you." And very and really that's not the experience if you have lived in Delhi like I have done for 5 years. So, what is this patient centricity, and why do you think that pharma needs to adopt patient centricity? We'll come to the go-to-market later, but at least we a little bit of clarity on the fundamental as to what is patient centricity and why does pharma need to adopt a patient-centric model?
Yeah, sure. So maybe I will go back a little, back in history. Okay, and again, it comes from my very intimate curiosity of learning about history, and maybe because I studied for a bit anthropology. Now, if I look at look at pharma industry as a whole, and I would say Indian pharma is a tribal society.
All right.
Okay, and what are the characteristics of a tribal society? That we remain within. Okay, our legal relationship, our illicit relationships, all remain uh, within the society. Now, why do I say it's a tribal society? Because if we look at last 40 years, okay, all our M&As, collaborations, takeovers are within the society, okay, which means within pharma industry only, okay. Now, when we behave that way, okay, how do we are expected to do things differently, because that's our makeup, in a way we have created a special genetic strain, or a family line which kind of does, okay, this is how it is, and specific, if I may say, a caste system,
Right.
in a way. So why does it happen? To my mind, again, there are 7 points, and I will stay with 7 points for maybe next 2 3 points. The 7 points is to me, the first one is expectation of 40% EBITDA.
Okay.
Okay, if we look at our promoters or board members, anything below 40%, bordering to 30% are acceptable. Below that, at certain point of time, you will not be part of the industry. Okay, if you don't believe that concept. Okay, whether every company delivers it or not is different, but the belief is that between 30 to 40% should be the benchmark for EBITDA. Okay, now that is, I think, is an expectation, especially current scenario and going forward, is expecting expectations are not realistic. The second one to me is low product differentiation. Okay, and if we look at the way we have been operating for last 50 years, and we are almost a commoditized market. And to some extent, we have moved from a commoditized market to a lifestyle market, lifestyle marketing. But still, we are an industry which has very low product differentiation. And because of that, what we have done is put everything on product. So we are overemphasized on product focus. And because of that, the fourth point for me is an reach and frequency model. We believe that higher the share of voice, bigger would be my sales. Okay, and bigger my sales, higher would be my profits. Okay, so that's how we have been operating. Of course, there are exceptions, but that's has been the general trend. Now, for an industry which is 1,50,000 crore, if my numbers are right,
Yeah.
The amount of evidence that they generate, okay, it's minuscule. Okay, so that's my fifth point. Okay, very low evidence generation. Sixth point is use of data. Okay, we have large population of support functions. Okay, but what kind of data do we use? Okay, if we look at the industry, which is 1,50,000 crore, how many research organizations do we have? Okay, supporting us, majorly three. Okay, so that talks about how much of focus do we put on the use of data. And the final one, the seventh one for me, would be understanding of digital. Okay, and I have a theory for what do I mean by digital. And it's very how would I say, in a way funny. Okay, when the COVID hit us, so immediately we started debating on physital, which means we believed the fulcrum of our activity still is share of voice. So we replace whatever we have with the physical. Okay, so we started debating on physical, how it should be, what it should be, and then lots of data, I think, has been generated. How is it going to impact the share of voice? My question is it the way we should proceed? Okay, which means if you're still stuck on physical and share of voice, okay, we're still stuck on the product. Okay, so that's what I think are my 7 reasons why we behave the way we behave, from that tribal society mentality. However, if we look at the trends, the global trends, healthcare trends that I've mentioned, those will impact us, and we are a borderless world today. At the same time, we have our own issues, and which are very unique and peculiar to India. Okay, now again, I'll go back to my 7 points, and then the first of it is access to qualified treatment. And Anup, you would say 20 years back, the number of GPs that we had in our cities are vanished.
True.
Okay, so my family physician in Thane is 55 years old, or else the other GPs that we have are non-MBBS GPs. So what is happening is access to qualified treatment has actually reduced in most of the urban centers. The second point is overemphasis on super specialty. Okay, so every kid who comes out of medical school wants to be a specialist. Okay, which is fair. But at the same time, what have we done as pharma industry to create a parallel source? Okay, because we knew that if we don't do that, that the first people who would be hit would be us. On the other hand, we actually have moved from moved to a more specialized category. So we kept on creating our specialty business units.
Right.
So that's how we have done. Instead of influencing what was happening, we kind of ran along with what was happening in the environment. The third one is stigma around sickness. I mean, there is so much of data, so much of information, so much of use of technology, but still, if you look at stigma, even as middle class, look at COVID, the kind of stigma it has generated. Okay, it's unthinkable. Okay, the fourth one to me is physicians focus on quick care. On an average, we have seen if the GP is not my friend, forget about specialists. If the GP is not my friend, you are in and out of the chamber as a patient within 2 minutes. Okay, so what dialogue can happen between a physician and a patient? Okay, which means it has an impact on the quality of life issues. That's my 6th point. Okay, and the 7th point is you and I at least have some basis of knowing what is happening to us because of the information that are available. Educations have gone up, but what about the have-nots, the people who do not understand those intricacies? Which means poor health drives poor productivity and hence rebound poverty. So I think one of the major situation that we are facing is rebound poverty, and COVID is a good example of the migration of the labor from all the big cities. I'm sure we would realize that all those people who had a decent life, okay, kids who are going to decent schools, gone back to maybe 20 years because they lost everything that they had. So these are very peculiar and intrinsic Indian issues which will have impact on the pharma, the way pharma would like to behave. Again, I would say that we really have to look at each of those to understand what is the patient journey and hence the patient stratification. Okay, so to add to that, the last one is the first one of my global trend is fear of travel. Okay, so these are the seven that I think are intrinsic Indian issues: access to qualified treatment, overemphasis on specialty segment, super specialty, stigma around sickness, physicians focus on quick care, quality of life issues, poor health, poor productivity, rebound poverty, and fear of travel.
So great, in a way, your 7 point sums up the kind of demographic shift that has happened in medical practice. From it being the family physician or the GP centered one who then referred you to physician, what we are experiencing is like a vanishing of the GP.
Yeah, absolutely.
And sadly, that vacuum still remains, which is why even in a city like Mumbai, you will find that the GP has vanished, but he has been replaced by the quack.
Yes, absolutely.
Even in a city like Mumbai. So, I'm getting the thread as to where you're driving towards as a responsible organization. The healthcare is not just a business, but it's a responsibility as well. So, I'm getting at where you're going is that why the farmer needs to move from a product centricity towards becoming patients. And as you rightly said, we are because of the emphasis on EBITDA, we are focused on driving the sales and therefore on the products. So, how do you think Indian pharma can make this shift uh, from product to patient centricity?
Yeah. So again, I would say that one of the factors that I strongly believe is of course the industry is extremely meritocratic. Okay. I have a lot of expectations, however, from the promoters and board members of the industry. So and lot of these big Indian companies are on second generation and third generation. Okay, now the people who started the organizations had a different view of the world. The world was different versus what it is today, and how it changing so fast. I was telling you about the VUCA example, and in India is actually instant VUCA, not just VUCA, it's instant VUCA. Now, many of those second generation, third generation promoters are foreign educated. Okay, they have learned their skills. They have learned their, or they have learned points in Western world. Okay, now how how do you imply those learnings to what is happening in India? And if you're talking about instant VUCA, it's almost impossible to understand it. And now that I'm living in 2.5 years in Brussels, it's very difficult to realize what can change, say in Mumbai. I'll give you an example. We were trying to work on a social business model, especially for epilepsy in Mumbai slums. So one of my colleague who is a Belgian, he actually accompanied me, and we planned it in such a way that he comes to Mumbai in the month of July. So it was second week of July in 2019, and so he could not believe that a slum which is within 4 kilometers of a tertiary care center, a large tertiary care center, why patients could not go to the tertiary care and get epilepsy treatment. Okay, I said, okay, wait. We landed in Mumbai, and it was, of course, July Mumbai. It's very nice, the temperatures are nice. So we had a meeting in Bandra at 10:30. Okay, and we left our hotel in Thane at 8:30. Okay, it should take. Google said that we should be reaching there by 10 o'clock. Okay, and we landed up at 12:30.
Okay.
Yes, I mean, who lives in Mumbai? Of course, I've experienced it. That on 15th of July, 16th of July, most of the most of the years it would take about 2.5, 3 years if you had a high tide and all this stuff. So I said that 22 kilometers took 3 hours. So then he realized, I never had to tell him again, why does why does a person living in a slum, which is within 4 kilometers of a tertiary care hospital, which is free, still doesn't get optimum treatment for epilepsy? Okay, so that is something which we have to realize, that that it's a different world. Okay, so what decisions do we make in terms of making that transition is critical for future, for us, and also critical for the whole economy. Okay, because pharma industry as a whole employs a large population of youth. Okay, and hence it's important that we remain sustainable. Okay, now coming back to what would be the my ideas for a transformed G2M go to market model. Now we do have stratification, okay, of course, but that stratification is more product stratification. Now how do we make that shift to patient stratification? Okay, we have processes where we do brand plan, yearly brand plan, but I'm not too sure the patient journeys are updated that regularly, and that's my personal experiences. What kind of data that we have generated to update our patient journeys? Okay, what kind of customization do we have in geographies? So we do realize when we have worked in the markets that the patient journey of Hiranandani is very different from the slum that we have next to it. Okay, but are our patient journeys aligned to it? I don't think, because we are product focused again. Okay, so the question is, what kind of decision do we make in those boardrooms is to make that transition. However, I have 5 propositions. Okay, now these 5 propositions, of course, many of are known to you, and I'm not saying something that is not happening in India. There are archetypes already available in India. The first one is build model on internet services. Okay, telemedicine and use of 4A. Now, I'm sure all of you are aware about the 4A that I'm talking about. It's awareness, access, affordability, and actors. So that's my first one, the first proposition. Second one is use of technology to free up routine tasks and make room for empathetic care. That's critical for the next stage of patient stratification and patient journey, empathetic care. Okay, and for that to happen, we have to free up time from qualified physician. Of course, there are diseases which would need personalized care. So hence, personalized care with better use of algorithms and decision tree. Okay, which means that we have to develop quantitative capabilities. Okay, and I think it's available at this point of time. Fourth one for me is integrate large volumes of data for holistic wellness-oriented treatment. Okay, people who can afford it should get it. Okay, instead of all the confusion that we have in terms of lack of credibility, lack of benchmarking. We should have that, which is the data driving holistic wellness oriented treatment. And the fifth one for me is critical, which is help prepare healthcare professionals for future. So these are my 5 propositions to all those decision makers that move away from product stratification to patient stratification, hence integrate patient journey into the business model.
So that's a very good insight you have given. About, especially when you mentioned that just 4 kilometers from a good tertiary care center, that too which is available free, and it's not easily accessible. So while on one side, the pharma industry has grown very well. I remember when I was a rep, it was, 200 crore was the size of the entire industry in the 80s. And then you have a division which is, doing 200 crores. Uh, so they have done
Products actually doing 200 crore. I mean,
right, right.
yeah, I mean, products doing 200 crore in 2 years.
Yes, the top brands like Glycomet or Mixstart are all 500 and 600 crore
Yeah,
products.
exactly.
That's
Yeah.
that's that's amazing. And the doctors have done extremely well too, regarding their lifestyle, their earnings, and the corporate hospital, the glitzy life. They live a very very reasonably good life. But the pharma industry and the doctor medical community is supposed to serve the patient, he's the one who is really feeling the pinch of it all.
Yeah.
Uh, whether the lack of infrastructure and simple things like drugs in a government hospital, or like you said, the patient getting just 2 minutes with the doctor, and ending up with a prescription which he hardly understand and which he is supposed to comply with. So I really see the need for the shift from product centric to being patient centric, to make this more meaningful as well as a sustainable business model. So that's a great point that you have raised. And I think that this COVID particularly has made all of us aware that you cannot live in islands, and even if you live in a fortified palace like Jalsa, like Amitabh Bachchan, because your servants are coming from slums like Dharavi, you will end up with the same. The virus doesn't make a distinction that you are a superstar and somebody is a poverty stricken. So there
Yeah,
is
I mean, yeah, I mean, again, going back, it's actually teaching us about democracy, and here we are talking about nationalism, right? Uh, uh,
so there is the need to provide a certain basic amenities to everybody, because if your neighbor is living in an unhealthy environment just a kilometer away, like you said, when you go to Hiranandani and you come out and you see those slums, which would be harboring all kinds of germs and all kinds of infections, is just a whiff of air away from all those beautiful expensive apartments that are people are living in. So I think it's not just the farmer, but I think uh, there is a complete need for shift from in the government, in the healthcare, everybody in healthcare, to make that shift to be patient focused. And I think, as you said, that to some extent, I think the policymakers are aware of it. So there is the drive towards universal healthcare, so that at least the basic minimum healthcare facilities are provided to all the citizens,
yeah,
without
absolutely. And I have a name for it, as I call it, most for most.
most for most. That's very good, because I think in the Nordic countries, as you mentioned, especially, that is practically become a reality, isn't it?
Absolutely, absolutely. But they have the challenges themselves, and probably I will share it with you a little later,
Right,
where they say it's not going to work, and they're
right.
talking about it in 10 years time. They're not talking about it in further future. They're saying in 10 years time it's not going to work for them. Okay, so picking up on the 4A model, something that you have mentioned is so much integrated. If we are talking about a patient stratification, okay, hence and learning from the patient journey. Now, when I look at 4A, the first part of it, awareness part of it, okay. Now, how do we address stigma? Okay, it's something that we have to be proactive about, and we have great examples on how do we address stigma. Of course, we have partnered, collaborated tremendously. Industry has collaborated tremendously. I mean, good examples are the vaccines. The way we have really overcome some of the challenges that were there 15 years back, 20 years back. When I think of, The cataract surgery, it's something a great job done by private players along with governments. And hence I think there are archetypes available which we can integrate and make it massive. And what we also have to realize that the industry is big, really big, 150,000 crore. Okay, that's big number, and the amount of people that we employ is something that every politician should be thankful of us. Okay, how are we using that? Okay, are we using it the right way? So coming back to awareness, stigma, gender, okay, and we talk about participation of women, the only way to democratize our population, growth of economy. Every time we see that if it is a disease, a woman is always bigger sufferer than a man. Misconceptions about how treatment should be, what is it, and the kind of misconceptions even today, even now we have on COVID.
Right.
It's again is a discussion, deeper discussion on knowledge versus information. Compliance is something that we really need to work on, and many more in case of awareness. But those are something that I think can be addressed quickly and incrementally. The second one on access, access pretty simply is diagnosis, qualified treatment, and I really push that. Qualified treatment is very important if we really have to leave our demographic dividends that we talk about. Okay,
Right.
25, 26 year average age of Indian. If we are sick, we cannot provide the dividend that we talk about, and hence we need qualified treatment. Care, okay, and not just treatment, but post-treatment care, and there are a lot of examples of palliative cares in India. But again, those are in silos. Those are in small numbers. Distance, as we have discussed quite a bit, 4 kilometers away, Sion Hospital, still you have a huge gap of epilepsy treatment. I'm sure for any other treatment in Dharavi, that's 4 kilometers, right? Sion Hospital is. Availability, okay. Now the confusion that we have is between what is available and what is not. Okay, now whether first we get the available diagnosis, available treatment, available medication, etc., all those are important. More importantly, available physicians. Okay, I remember going back in my early days is PHCs, primary healthcare centers in district in districts used to be a key place for patients to come from farther aways. I'm sure in last 25 years things should have moved in the right direction. Has it moved in every other state the right direction? Okay, what kind of PHC infrastructure that we have created? And the last one that I think is very important for access is data generation. Okay, so every time a patient walks into a physician's chamber, what kind of data do we capture and generate? And that probably will drive the amount of complexities that we're talking about, which should not be based on simply on the whims and fancies of one person, okay, and 2 minutes of interaction.
Yeah.
Okay, so we have to generate data. That's as simple as that. Affordability, it's something that you have said is as Ayushman Bharat is a great example, most. But at the same time, for me, my insurance is connected to people like me. Our insurances are connected. Say health insurances are connected to our jobs. Why should it be? So if I lose my job, my insurance is gone.
Yeah.
Okay, so a large population of taxpayer Indians, their insurance is connected to the job. So what happens to them? So you have a population, 60 crore population, which will get benefit. But what happened to the taxpayer community, 4 or 5 crore, whose whose insurance is connected to the job that they do. So what are we doing about it? Uh, then cost of treatment, because more data we generate, the same thing, like digital or technology, there's a drop of the total treatment cost. And I'm not talking about cost of drugs. That is something that we need to go beyond. In the name of competition, we should not have, already how many favipiravir or something like that, which is okay, this is seven or eight,
Yeah,
eight versions of that in India,
right,
and each one is cheaper than the other one. And I remember the vildagliptin story. Something like 100 brands were launched. One to the lowest was something like 4 rupees or 3 rupees.
right.
Does it ensure the cost of treatment? This is something that we really need to address. Quality of life in terms of affordability, because that's something we need to tag along with affordability. Affordability is not about cheap treatment, cheap medication. It's about quality of life. What happens to me in terms of my productivity? And connected to that is rebound poverty. Okay, if you're talking about 25 crore population, which is below poverty line, I'm not too sure whether that's the right number. uh, how many of them are actually going above the poverty line, and how many of them are actually coming below the poverty line every year because of the diseases that they have? Okay, and the final one that I want to talk about for A is actors. Okay, and the first word that comes in my mind is collaboration. How are we collaborating with non-governmental organizations, governments? Okay, good examples are there, as we see across the world, like never before, because of the COVID. The corporations are really shaking hands with governments to come out with a solution, and we see very good outcomes coming up with that. However, that collaboration has to define impact. Okay. Now, every actor who comes into the play has to define the impact of it. Okay. If there is no impact defined and the period defined, I think that's a big question mark that we have. Okay. So how do we define impact? And again, that impact is based on the data that we generate. Okay. And finally, the investors are the actors. Whether they are investing on the right project, okay, whether they are still looking for a 40% EBITDA or a 30% EBITDA, or they're looking for a sustainable model, which we're talking about healthcare, which is linked to how India would progress in next 20 years. Okay, so these are my four A. I strongly believe that this can be integrated in a sustainable way, and many of those infrastructures are already in place. Okay, I would say that it's not a very difficult job to integrate these four A's. Okay, at the same time, the key is the paradigm shift in mindset, and which is more anthropological than anything else.
So great. I think very valid points that that in India we have a lot of stigma attached. Whether it is epilepsy, I think the stigma attached to it is, or mental health, because of the belief systems that we have, and COVID has only amplified that. Once more stigma has been attached, even by the so-called educated people. you know,
Absolutely.
where you are refusing accommodation to doctors because they are more exposed to COVID. So I think, so being centric is, not just bringing 10 brands of Favipiravir and saying that we are serving the community or we are giving it at the lowest price, but I think it's a lot of work that the pharma company has to engage, as you said, with different actors who can actually disseminate this awareness and remove the stigma and make people more, what should I say, open to receiving the right treatment at the right time, which should be accessible as well as affordable. Great thoughts, Sudeep. I think we need to do one more session with you to, kind of make this easier for pharma companies to take it in. Because see, for most companies, building mega sales force have worked very well so far.
Yes.
And as you said, the share of voice, it continued to play an important role along with maybe share of the market. So if I want to increase my share of the market by so much percentage, how much bigger do I need to make my field force? So you have all these figures of field force, which are, there are companies which have got 10,000 field force people. So how do you think this will change? It will change now because of the COVID and the lockdown and the inability of the field force to be more effective or fully effective, and in the future.
Yeah, one of the major issues that I foresee, in the model that we have at this point of time, the share of voice model, and quickly I'll go through, is the productivity issue. Okay. Now, if you have, and I'm sure most of the companies is going through that productivity issue. Okay. Now, if the productivity should go down, which means there will be drastic reduction in employees. Okay, it's very, very, very obvious. Okay, now when that happens, what will be the next stage? Next stage will be IR issues. Okay, which will be employee disputes. Okay, which means further impact on the way we run the organization. Hence, our operational expenses would be impacted. So it's a chain of events which finally is going to impact patient and patient journey. Now, how do we swap it, put the patient first, and then do the rest of the things? Okay, so if we are talking about physical, okay, replacing physical reps with a digital communication, thinking that share of voice will remain. And what about the rest of the things? What about the employee disputes? What about the IR issues? What about the impact on the operational expenses that you will have? What about reduced profits? Okay, what would board say? What would shareholders say? Okay, what about long-term benefits of long-term health of industry? Okay, so I think these are something that we really need to discuss quickly, faster the better, ASAP.
Great. I think we're coming quite close to the end of the session. I think we have about 10 minutes or 7 minutes to go.
7 minutes.
So in the remaining time, just one last questions. What can pharma do to help the doctors, prepare for the future and, so that they remain, they remain relevant to the problems that patients are facing, and they can be more, effective in making healthcare available to everybody.
So I would actually redefine the doctor part, Anup. I will call it as healthcare professional, HCPs. So we probably in next 5 years will never have enough number of doctors. So better call it as healthcare professional, and we can do that. And I think I saw a video from Dr. Devi Shetty. Yeah. And I think that was a very good video in terms of what he defined, how it should be. So I'm not an expert on that, but I think what he said made sense to me because of spending all the time in the industry. Now, I'll give this example. I talked about Danish Design Center in Copenhagen. I happen to work with them. And they have this research they did in Denmark, of course, is that by 2030, every Danish student has to be a healthcare professional.
Wow.
If they have to manage the current load of disease, if they have to manage the current disease burden, the way it is managed today, considering that Denmark probably is one of the best healthcare system, they're saying that every student will have to be a healthcare professional, even in their country, the way it is. So when I try to make a parallel and think of the lowest common denominator, I think of Thane. What will happen to Thane? Because that's where I live. And I shudder to think, my God, what it can happen. And COVID has really exposed it so much
Yeah.
that what can happen to us if we don't really prepare ourselves. So to my mind, the healthcare professionals of future, okay, of course, huge amount of technology and data would be there. So again, I have three actually thoughts on that, and many of those thoughts are again summation of the data that I have seen, the researches that has been done by a lot of consulting firms. The first one is relationship oriented skills. So the fundamental of an HCP has to be relationship oriented skills. I don't want to speak more on that. And we have seen the side effects of lack of relationship oriented skills.
Right.
Okay. So much of mistrust, distrust, violence against HCPs. Somewhere it is there. Okay. Now, can it be measured? Yes. Can it be taught? Yes. Can it be improved? Certainly. Okay. And we know that these are associated with better patient outcome and of course the clinical competence of the HCP. And I think if we listen to Atul Gawande, and he talks hours and hours on palliative care versus the surgery that he did or the hospitalization that he speaks about. And I think this is something that we as pharma we should focus on. The second one is technological advancement. The thing is that preserve the well-being. Okay, if I am fit, how my HCP helps me to preserve the well-being. Okay, and this is something that pharma can help. Okay, avert illness. It doesn't mean that reduction of our sales. Okay, there always will be alternative method to make profits, and we have seen it more and more. Equal value of technical skills and human capabilities. That's what the HCPs would need. Preserve well-being, avert illness, equal value for technical skill and human capabilities. How many degrees you have should not define how good a physician or a treater are you. Okay, and interdisciplinary practice, the third one to me, which means reading and use of data. They can amplify population health, okay, by reading data, enhancing the care by interpreting complex information, and to predict and avert illness. So that I think is something we can help for future healthcare professionals. Okay, and I think I strongly believe that pharma industry has the infrastructure.
So great talking to you, Sudeep. It's some really wonderful insights you have given to us. I think we have to move from the 30-40% EBITDA mindset to how many Indians can the pharma industry impact positively in terms of improving their healthcare. So pharma has to make a big shift from its product centricity to become patient centric, to understand their challenges and how that can translate into a sustainable business proposition for pharma. And more importantly, you also brought out that given the doctor to patient ratio in India, it's not possible that doctors alone will be able to address the humongous healthcare challenges. So it's right to define the entire across spectrum of the medical fraternity, whether they are doctors, whether they are nurses, whether they are pharmacists, whether physiotherapists, or more importantly, given our obesity epidemic, which is at the root of most of the lifestyle diseases, and I think which has again exposed this huge challenge, because most of the people we are seeing who have gone into critical illness have been those people with obesity and underlying diabetes and hypertension, which has led to the increase in morbidity and mortality of this. So really the challenge is that who can help these patients to not just keep taking drugs, but enable them to adapt lifestyle changes, and maybe the pharma will have to bring in new actors to play. Maybe the people like who are able to develop good digital therapeutics, which help the patient to understand what is happening to his body, and therefore reach the healthcare provider at the right time when the symptoms are still in a manageable stage, rather than going into a crisis and ending in the ER or in the ICU. So wonderful, Sudeep. Great talking to you. And I look forward to one more session, because this has been something completely that different topic that we don't hear about. But I think in the West you hear more about it, and therefore you are more aware of it. But I think it's good of you, people like you, to come and share this on this platform with us for the benefit of the Indian pharma professionals. I think this topic has relevance beyond the pharmaceutical industry, and pharma would do well to partner with people like you to take this message across the industry. So thank you once again. Good evening, and thank you to all our participants for staying with us. Do tune in on Friday, 2 days from now, day after tomorrow, at 5 o'clock, when Sudeep will have more time to explain this entire topic of how to use patient centricity as the new go-to-market model for pharma. So thank you for setting the context, Sudeep.
And thank you very much, Anup. Thank you very much, Medicine Man and CredoWeb. And thank you, friends, ladies and gentlemen. Good night and have a nice weekend.
Thank you. Bye-bye.